So, hello and welcome to today's session. Today we are looking at osteoarthritis. Osteoarthritis is one of the major common conditions of the musculoskeletal disorders, and it majorly affects the joints and joints of the bearing weight joints. Okay, so this is a progressive inflammatory degenerative disease of the diarthrial joints. And these diarthrial joints, these are joints that freely move. Okay, remember in terms of physiology, we have three classes of joints. They are normally abbreviated by the word SAD, where this one represents sina arthrosis joints, ampia arthrosis joint, and diarthrosis joints. So diarthrosis joints allow free movement, little movement, slight movement. Okay, let's proceed. So in these diarthrosis joints, they have the synovial cavity that is normally fluid filled in these connecting points. In this region, the articular capsule is normally made up of the cartilage and the fibrous tissue. We have already indicated that osteoarthritis majorly affects weight-bearing joints such as the hip joints and the knees. Okay? Osteoarthritis is also the most common form of joint disease. Okay? Remember, it is closely related to rheumatoid arthritis. Guys, a link will be popping up on the differences between osteoarthritis and rheumatoid arthritis. So osteoarthritis causes disability that ranges from minor limitations to near immobility. We have varying progression rates, and this disease is normally referred to as degenerative joint disease. Degenerative joint disease. Okay, great. So what is the pathophysiology? In pathophysiology, this disease involves three stages: stage 1, stage 2, and stage 3. So first of all, we normally have the cartilage swelling from increased production of protoglycans. Remember, protoglycans are glycosylated proteins which covalently attached to highly anionic glycosaminoglycans. So many of forms of the protoglycans are present virtually in all extracellular matrices of the connective tissues, of which joints is one of them. So from the swelling of the cartilage, it leads to joint cartilage deteriorating. Okay, it swells as a result of increased production of the protoglycans, and then eventually the joint cartilage deteriorates, and this sets in stage 1. So we have the reactive newborn forms at the margins. Now that this one has deteriorated, it has to be replaced by another reactive newborn, which forms at the margin and the subchondral areas. So we have the chondrocytes. They break down. And when this break down, the cartilage erodes and flakes, irritating the synovial lining, setting in stage 2. Setting in stage 2. So the cartilage breakdown leads to the release of cytokinins. And when the cytokinins are released in the synovial fluid, it sets in stage 3, which now we are now going to have inflammation. But remember, inflammation was never the cause. Okay, it was because of the swelling as a result of production of protoglycans, and then it deteriorating, then being replaced by a newborn, and then now the chondrocytes breaking down, cartilage eroding and irritating, producing now the cytokinins in stage 3. So cartilage lining becomes fibrotic, and chronic inflammation further adds the breakdown of the cartilage. So joint structure is affected and movement is limited. Synovial fluid leaks into the bony defects, causing cysts. Okay, correct, guys. So here is like for the hand, guys. We normally have the Herbardian nodes and the Bouchard nodes. How to go the difference between the two is this one's there. Bouchard, okay, butchered, proximal. Yeah, I've heard guys saying proximal instead of proximal. Yeah, so butchered is proximal to the body. Yeah, so you can feel it here. Whereas Habadan nodes, they are away, they are high. Okay, they are high away from the body. Okay, this butchered, they are proximal. Okay, so the joint space normally is narrowed, okay, as a result of more bones tissue being formed there, and this one normally irritates the synovial membrane and therefore releasing the cytokines that sets in inflammation. So this is for the hand, okay? So osteoarthritis also can occur in the hands, okay? Correct. We also have one for the bones and then the knees, which where it is very common, and you can appreciate the erosion of the cartilage and the erosion of the bone and having extra bones, hence reducing this space, okay? We also have the erosion of the cartilage here, then the joint space narrowing, and then the addition of the osteophyte. Okay, yeah. So those are some of the signs and symptoms of this condition. We have the causes of this condition, the causes of osteoarthritis. We have congenital abnormality, where structural abnormalities present from birth can lead to this irritation, leading to release of cytokines that sets in the inflammation. For the endocrine disorder, we have conditions like diabetes that predispose the gland to such. Hereditary, we have genetic factors that may increase the susceptibility. Also for the metabolic conditions like the chondrocalcinosis, secondary arthritis develops as a result of another underlying conditions. We also have traumatic injury, where physical injuries to the bones can set the process of moving from the stage 1, stage 2, and stage 3, that finally there is inflammation. So also infection, joint infection can lead to arthritis. We have risk factors of osteoarthritis. One of it is advanced age. So as people age, the cartilage that normally cushions their joints may naturally degrade over time. This may lead to osteoarthritis as joint surfaces become less smooth and less able to absorb shock. We also have the female sex. Okay, so women are at a higher risk of osteoarthritis than men, particularly in the postmenopausal years. So hormonal changes, including reduced estrogen levels after menopause, may play a role in this increased risk. Also, obesity is another risk factor. Excessive fat or weight places added stress on the weight-bearing joints, such as the knees and the hips. So this additional stress can accelerate the wear and tear of the joint, of the joint cartilage, leading to osteoarthritis. Also trauma, a history of joint injuries such as the fractures, ligament tears, or dislocation can increase the risk of developing osteoarthritis in the affected joint. So trauma can disrupt the normal joint mechanics and accelerate cartilage damage. Muscle weakness. So weak muscles around a joint can fail to provide adequate support and stability, which may lead to abnormal joint loading and wear and tear of the cartilage. So strong muscles help protect joints from excessive stress. Repetitive use of a joint, so engaging in repetitive high impact activities or occupation that place consistent stress on the particular joint can contribute to the development of osteoarthritis. So over time this repetitive strain can damage the joint cartilage. We also have previous rheumatoid arthritis. So rheumatoid arthritis, of course, we have said we have a link that is differentiating between the two conditions, but you're saying this condition is an autoimmune disease that affects and can damage joints. So if someone has had rheumatoid arthritis, it can increase the risk of developing secondary arthritis in those affected joints. Also infection. So joint infections can cause inflammation and damage to the joint structure. This can increase the risk of developing osteoarthritis in the affected joint as biochemical, okay, and immunological factors may be altered. underlying bone conditions or deformity. So conditions such as avascular necrosis or congenital joint abnormalities can disrupt joint function and lead to osteoarthritis due to abnormal biochemical and structural issues. The last risk factor is genetics, and genetics can play a role in osteoarthritis susceptibility. So you find some individuals may inherit genes that make them or make their joint tissues more prone to damage or less capable of repairing themselves. This increases the risk of osteoarthritis. So what is the incidence of osteoarthritis? Osteoarthritis occurs equally in adults up to age 55. So this is so after this you find that females are more exposed or vulnerable to this condition because of those postmenopausal changes. This disease is typically develops around age 40, okay, and it's more common type of joint and affects over 30 million Americans. Is the leading cause of disability for adults older than age 65. Complications of osteoarthritis. Number one, we have flexion contractures. So flexion contractures are a complication where a joint, often the knee or the elbow, becomes stuck in a bend or a flex position. So this occurs due to the progressive loss of joint motion and can significantly affect the joint's range of motion. We also have subluxation, and this refers to partial dislocation of a joint. Okay, in osteoarthritis, a joint surface may deteriorate to the point where they no longer align correctly. This can lead to instability and pain in the joint. We also have deformity, and osteoarthritis can cause joint deformities where the joint shape becomes distorted. Remember, the joint space has narrowed because of an additional new bone in it, new growth. Yeah. So in osteoarthritis of the fingers, for example, joints may become enlarged or knobby, leading to a noticeable deformity, where we have been talking of the Herbardian and the Bouchard. Okay. The Bouchard is proximal, whereas the high is high, okay, away from the body, okay. Ankylosing. This is the complete fusion or immobility of a joint. Okay, so in severe cases of osteoarthritis, joint damage can lead to ankylosing, resulting in permanently fixed joint position and loss of mobility. We also have the bony cysts. Okay, osteoarthritis in stage 3, remember? Yeah, it can lead to development of bony cysts or osteophytes. So these abnormal growths of bone at the joint margins, they can cause pain because of encroachment on the nearby nerves and limiting movement and further damage the bone. We also have gross bone overgrowth. In some areas, osteoarthritis can lead to significant bone overgrowth, causing joint enlargement and further impairing joint function. We also have the central cord syndrome, and in some cases of cervical spine osteoarthritis, pressure on the spinal cord due to bone spurs or other degenerative changes can result in central cord syndrome. So this condition can lead to neurological symptoms like weakness or loss in the function of the arms and legs. We also have nerve root compression. So osteoarthritis in the spine can compress nerve roots as they exist the spinal cord. So this can cause pain and weakness and numbness radiating to the limbs, a condition that is known as radiculopathy. We also have cauda equina syndrome. So in severe cases of lumbar spine osteoarthritis, compression of the cauda equina, this is a bundle of spinal nerves in the lower back, can occur. Okay, so this is a medical emergency and can lead to bowel and bladder dysfunction, leg weaknesses, and loss of sensation in the lower extremities. Cauda equina syndrome. We also have drug reactions. So some medication can be used to manage osteoarthritis, can have side effects or cause adverse reactions. It's essential to monitor and manage medications use carefully to minimize this reaction. Lastly, we have inability to work or perform various activities. So you find that as osteoarthritis progresses, individuals may find it increasingly challenging to perform their regular work or engage in previous activities. This can impact their quality of life and the overall well-being of the patient. On the assessment, yes, on the assessment, you're saying we start by collecting the subjective data through history, okay? And then objective data through physical findings. Okay, so let's start with history for the subjective data. The patient reports deep aching of pain or tenderness on palpation. The patient reports pain after exercise or weight bearing. Patients may report pain that may be relieved by rest. Patient may report stiffness in the morning and after exercise, usually lasting less than 30 minutes. The patient may also report aching in the joints during changes in weather, or grating feeling when joints moves, or limited joint movements or dexterity. Also, patients may present with or report a predisposing traumatic injury, okay, that may be led to their condition. So, guys, we can be able to appreciate the high Hubbard, Habanot, and the proximal, the chart, okay, swellings. In terms of the physical findings, that's what you find out. So you find out that the patient is having contractures, joint swelling, edema, or warmth over the affected joint. You could also find out muscle atrophy, deformity of the involved areas, gait abnormalities, hard nodes that may be red, swollen, tender, on distal and proximal interpharyngeal joints. Remember, the distal, we have the Hubbard chart, and the proximal, we have the bow chart. We also have the loss of finger dexterity, muscle spasms, limited joint movement, and joint instability. We have decreased range of motion, which with pain occurring at the end of the range. Then we have the crypticus. Okay, correct. On diagnostic tests, we have laboratory, then we have imaging. Okay, great. We start with laboratory, where we target the synovial cavity. So we get the synovial fluid for analysis just to rule out inflammatory arthritis. So this inflammation can lead to elevated levels of inflammatory markers in the synovial fluid, such as white blood cells may be elevated, higher levels of proteins like the C-reactive protein, CRP, and erythrocyte sedimentation rate. So inflammatory arthritis typically results in synovial fluid that appears cloudy. Okay, the synovial fluid will be cloudy or inflammatory under microscopic examination. From diagnostic, that is laboratory, we go to imaging. And imaging, we're interested in the x-ray of the affected joint, which may show narrowing of the joint space or margin or crystal-like bone deposits in the joint space and margins, sclerosis of the subchondral space, joint deformity, articular damage, bone growths at the weight-bearing areas, and possibly joint fusion. We also have the radionuclide bone scan that can be used to rule out inflammatory arthritis by showing normal uptake of radionuclide. Okay. Lastly, we have magnetic resonance, and this magnetic resonance imaging normally shows the affected joint, adjacent bones, and the disease progression. So, in terms of diagnostic procedures, we find that we have neuromuscular tests that may show reduced muscle strength. We also have arthroscopy. Remember, arthrosis is a joint. Arthroscopy, this is the internal joint structures. You're looking at the internal joint structures. So you want to identify soft tissue swelling. You want to help rule out inflammatory arthritis, infection, and crystal arthropathy. In terms of treatment, we start by general. We can start with general treatment. Then we go to diet. then we go to exercise, then we go to medication. Okay, so let's start with general. You find that you have to do weight reduction if they are obese. Okay, so anybody above BM above 30, we have to reduce the weight because excessive weight puts added stress on the weight bearing joints like the knees and the hips. So weight reduction can help alleviate stress, which reduces pain and slows down the progression of arthritis. So a combination of a healthy diet and regular exercise is typically recommended for us to achieve this. We also have the heat or cold or both therapy. We can use heat, cold or both. So heat therapy involves applying warm compresses or heating pads to the affected joint. This can help relax muscles and improve blood flow, easing stiffness and pain. Whereas cold therapy, this involves using ice packs or cold compresses, which can reduce inflammation and numb the area to relieve pain. So some individuals find relief with alternating between heat and cold. Okay, so here heat, you're improving blood supply, okay, to the joints, and the cold, you are trying to reduce inflammation and numbing the area to relieve pain. Next, we have ultrasound therapy. So this involves the use of high frequency sound waves to generate heat and promote blood flow to the affected area. It can help reduce pain and improve joint mobility. We also have physical and occupational therapy. So this one focuses on improving joint function, strengthening muscles, and teaching techniques for managing activities of the daily living. So physical therapy involves exercise and stretches, while occupational therapy helps patients adapt to their environment and perform tasks with less strain on their joints. We also have the use of assistive devices. So devices such as braces, the splints, orthopedic footwear can provide support to the affected joints, reducing pain and preventing further damage. So these devices help protect the joints from overuse or misalignment. Also have complementary therapies, practices like the Tai Chi, that's majorly performed in the Middle East and Far East, yeah. Tai Chi, the massage, the acupressure, acupuncture, hydrotherapy, relaxation techniques. This one may offer pain relief and improve joint flexibility. While they may not directly treat the underlying condition, they can be used as complementary approaches to manage symptoms and improve the well-being of an individual. Next, we have the VTE prophylaxis, the venous thromboembolism. So when a patient with osteoarthritis undergoes surgery and is hospitalized, especially like for example the hip surgery, okay, a link will be popping up for the hip replacement surgery. So there is always a risk of developing venous thromboembolism, so which includes conditions like deep venous thrombosis, DVT, and pulmonary embolism, abbreviated as PE. So to prevent this potentially life-threatening condition, healthcare providers may prescribe blood thinning medication and or use of chemical compression devices to help improve blood circulation during hospitalization. Guys, we can look at the diet. What should be the diet for a patient suffering from osteoarthritis? Okay, so weight reduction diet if they are overweight or obese. Okay, then we need high fiber diet if they are taking opioids. Remember, opioids they normally lead to constipation. Okay, yes, so high fiber. Okay, to help us in this case. Also, you need to increase intake of omega-3 fatty acids. And the reason is you want to help them to reduce inflammation. Remember, in stage 3, inflammation sets in as much as it is a degenerative joint disease. Okay, a degenerative joint disease normally ends up in inflammation. Okay, so next we have activity. So activity should be as tolerated. We need to have lifestyle modification as necessary for their comfort. We need also muscle strengthening exercises like lifting weights, using resistant bands that are moderate or high intensity and that involve all muscle groups or on 2 or more days a week. Okay. Also need exercise that maintain and improve balance, moderate intensity aerobic activity for at least 150 minutes per week. Yeah. Next, we have medication, and then medication we start with the acetaminophen. Okay, guys, a link will be popping up on the discussion on acetaminophen. Okay, yes, so it could be topical or oral, non-steroidal and anti-inflammatory drugs, the NSAIDs such as the ibuprofen, the naproxen, and the diclofenac sodium, that is topical. Okay, also have topical capsaicin or other topical analgesics as an adjunct therapy for the knee or hand osteoarthritis. Then you have oral analgesics such as the codeine sulfate or the oxycodone hydrochloride, only for short-term treatment for the acute pain. Then we have intra-articular corticosteroids such as the triamcinolone acetonide injection or methylprednisolone for acute flares. Okay, remember this one should not be used more than 4 injections in a joint in a year. Okay, the client should not receive more than 4 injections in a joint in a year. Okay, intra-articular injections of hyaluronic acid can also be given. So glucosamine and hydrocoitin for symptomatic pain relief. Although research is inconclusive on this, okay, or with time it's going to be made clear. We also have colchicine as an adjunct in patients with frequent acute inflammatory episode who do not respond well to analgesics. We also have platelet-rich plasma injections. Okay, here we have autologous growth factor treatment. The surgery that is involved for patients suffering from osteoarthritis. We have arthroplasty. It could be partial or total arthroplasty. So in partial, it is also known as joint resurfacing or hemiarthroplasty. So this procedure involves replacing only damaged part of a joint with artificial prosthesis while preserving the healthy portions. It is often used in cases of hip or knee osteoarthritis where only one side of the joint is affected. Whereas total arthroplasty, this is also known as joint replacement. Okay, joint replacement is performed when the entire joint is severely damaged. It involves replacing the entire joint with a prosthetic device made of either metal, plastic, or a combination. So total joint arthroplasty is common done for the hips, the knees, the shoulders, and sometimes other joints like the elbow or the ankles. We also have arthrodesis or joint fusion. This one involves the surgical fusion of two adjacent bones in a joint. This eliminates joint motion entirely. It is typically considered when a joint is severely damaged and other treatment options have failed and are not suitable. So while arthrodesis sacrifices joint mobility, it can improve stability and pain relief. We also have osteoplasty, is also known as joint debridement. Okay, it involves removal of the bone spurs, the osteophytes, or other abnormal growths within a joint. It is a minimally invasive surgical procedure aimed at improving joint function and reducing pain by eliminating or reducing mechanical obstructions within a joint. Lastly, we have osteotomy. Osteotomy is a procedure where the surgeon cuts and reshapes bones around a joint in change to its alignment. This is typically done to redistribute weight-bearing forces away from the damaged part of the joint It is commonly performed in younger individuals with early stage osteoarthritis, especially in the knee. So osteotomy can help delay or avoid need for joint replacement in some areas. When you look at nursing responsibilities, for the nursing responsibility, you're saying we allow adequate time for self-care, encourage patient participation in self-care to the extent possible. So suggest assistive devices to facilitate independence with self-care, including hook and loop closures, grab bars, and reaching devices. You also need to administer the prescribed medication, and this medication could just majorly work on the pain medication to allow maximum rest and encourage the patient to take NSAIDs with food to minimize GI distress. Okay, this is the nursing responsibility that you need to know. You also need to screen for and assess for the patient's pain using the facility defined criteria. Okay, remember to look at the origin of the pain, the palliative or provocating factors, the quality of the pain, the region where it's radiating, severity, and the time. Okay, okay, fine. You closely monitor a patient who is prescribed opioid medication. Remember this one, they need to be given more fluids and need to be given high fiber diet because opioid treatment patients are likely to suffer from constipation. Okay, you also need to reassess and respond to the patient's pain by evaluating the response to the treatment and time management. Remember to employ both pharmacological and non-pharmacological modalities in treating this. You need to promote relaxation and stress management techniques. You allow the patient to verbalize the effect of pain. Okay, suggest ways to foster independence within the limits of the condition and assist the patient in practicing positive coping strategies. Remember to apply cold. You can apply hot. So you apply heat so as to improve circulation. You apply cold so as to numb the place. There's instances where you're going to use both of them. Okay, so you remember to inspect the skin before, during, and after application to prevent thermal injury. For affected hand joints, you need to use warm socks, compress, and the paraffin dips. Also for the affected lumbosacral spinal joint, ensure that the patient has a firm mattress. Also, for affected cervical spinal joints, apply a cervical collar if indicated. For affected hip, apply moist heat. For affected knee, help with range of motion exercise. Apply elastic supports or braces. Check for the assistive devices such as the crutches, okay, canes, brace, walkers for proper fit and encourage patient demonstration for proper use. Okay, there's a link on the proper use of the cane, the crutches will be popping up. You can review. Apply also the anti-embolism stockings or sequential compression stockings to prevent venous thromboembolism if the patient is hospitalized. Remember to institute safety precaution to reduce patient's risk of falls. Okay, reinforce the treatment regimen and then prepare the patient for possible surgery, including explanation about what to expect postoperatively, such as weight bearing activity restriction as appropriate. On patient teaching for the general, remember that you need to include the family or the caregiver in your teaching when appropriate. You provide information according to the individual's communication and the learning needs, and you need to cover on the disorder, underlying causes, diagnostic testing, treatment, including heat therapy. You also need to talk about the need for adequate rest during the day, after exertion, or at night. Also, the need to allow time for the morning for the stiffness to resolve. Okay, the stiffness is there in the morning, but it resolves. It takes less than 30 minutes. This is different in rheumatoid arthritis, where it takes more time. You also have energy conservation measures. That is what you are supposed to teach the patient. pain management. You also look at the safe use, storage, and disposal of the opioids. Prescribed drug therapy. You need to know the drug name, the dosage, the route, the frequency. Guys, the rights of drug administration. Okay. So possible adverse effects of each medication, including GI distress, like for the NSAIDs. Okay. NSAIDs, you take the drug with food so that you don't suffer from GI disturbance. We have proper application of topical NSAIDs and possible local banning of the topical casein use. Need to use NSAIDs with food to notify practitioner if bruising or bleeding occurs. Also need to do exercise plans such as the ROM exercise, and they need to perform them gently. Proper use of the heat to the joints, including the need to protect the skin from burning, the use of proper footwear, home safety precautions, including installation of safety devices, importance of maintaining proper weight to avoid overstressing the weight-bearing joints. Okay, use of the crutches and other orthopedic or assistive devices. Also talk about importance of adhering to follow-up appointment to evaluate the effectiveness of the therapy. And lastly, the post-operative care measures, if appropriate, include any weight-bearing restrictions. Okay, so on discharge planning, you need to participate as part of the disciplinary team to coordinate the discharge plans. It is the role of the nurse to make sure that the team has included the bedside nurse, social worker, care manager, physical therapist, occupational therapist, nutritional, primary healthcare practitioner, and the surgeon. Also, the RN determines the appropriate post-hospital setting where the patient should be discharged. The RN also assesses the patient's family and the patient's understanding of the diagnosis, treatment, prognosis, follow-up, and warning signs for which to seek medical attention. The RN also evaluates how the current illness will impact the patient's independence. Remember, the role of the nurse is to treat the human response to illness. Identify the patient's formal and informal supports. Identify the patient's family and family goals, preferences, comprehension, and concerns about the discharge. You need to provide a list of prescribed medication, including their dosages, the prescribed time schedule, adverse reaction to report to the practitioner, and provide the patient with written information on the medication that the patient should take after discharge. Remember to assess the patient's and family's understanding of the prescribed medication, including the dosage, administration, expected result, duration, and possible effects. Also need to assess the patient's ability to obtain medication, identify the party responsible for obtaining the medication. Then RN needs to ensure that the patient can open all medication containers or provide easy open tops for the medication. Instruct the patient to provide a list of medication to the practitioner who will be caring for the patient after discharge, to update the information when the practitioner discontinues medication, changes dosage, or adds new medications, and to carry a medication list that contains all medications or this information in the event of an emergency. Ensure that the patient and the caregivers receive proper contact information for medical and psychological support. Provide information on the local support and services. Ensure that the patient or caregiver receives a copy of the discharge instructions and a copy is placed in the patient records for reference. Lastly, you need to document the discharge planning evaluation in the patient's medical record, including who was involved in the discharge planning, teaching, their understanding of the patients, okay, and any need for follow-up. So, guys, that is the short presentation on osteoarthritis. A link will be popping up again. You can be able to review the difference between osteoarthritis and rheumatoid arthritis. Also, to access a practice quiz so as to test your knowledge and reinforce your understanding, kindly click the link in the description section.